Good morning. I'm Laura Wills, Assistant Director of the National Center for Primary Care and the Administrative Director for the National COVID-19 Resiliency Network. What an exciting morning. We've already gotten off to a really great start and heard from our incredible leaders who've been and continue to be thought leaders in the fight against health disparities. And we're going to continue this momentum and bring you interesting and thought-provoking information throughout the next 2 days, starting with our next session, our Fireside chat featuring the past and current leaders of NCPC. I've worked at NCPC here at Morehouse School of Medicine for 10 years, and I've been lucky enough to work with two of NCPC's incredible directors, Drs. Russ and Mack. And you've met them already, but I just want to say thank you to Dr. Russ for your leadership over the years. I have often been moved by your commitment to fight for those who deserve better from a healthcare system that should and can do better. Our current leader, Dr. Dominic Mack, with whom I've spent the majority of my 10 years at NCPC, is an example of true servant leadership. And I think it's safe to say that each of us at NCPC feels honored to not only call him our leader, but a mentor and a friend who each and every day teaches us invaluable lessons. In just a few moments, we will have the unique opportunity to have a front row seat to hear from three men who have years of experience in the fight for health equity. These previous and current NCPC directors, Dr. Russ, Dr. Mack, and Dr. David Satcher, have led the way and been instrumental in keeping the conversation going and ensuring health equity has a seat at the table whenever and wherever healthcare is discussed. During their chat, they will discuss their own personal experiences as primary care physicians, researchers, and public servants. And they will highlight some of the most important accomplishments in the journey to achieve health equity. They will also do what they do best, guide us towards the future, and provide us with thoughts on the most immediate needs and actions for today's and tomorrow's leaders. The conversation will be moderated by one of those leaders, Dr. Chelsea Cohen. Dr. Cohen is a second-year resident in the Family Medicine Residency Program here at MSM. She is also one of the first of 4 residents participating in the health equity track. Dr. Cohen has a passion for community-based solutions to address the social determinants of health. She studied anthropology at Washington University and attended medical school at University of Southern California Keck School of Medicine, where she also earned her master's in public health before returning home to Georgia for her residency training here at MSM. Welcome, Dr. Cohen. It is my distinct pleasure to introduce Dr. David Satcher. Like many men of his distinction, Dr. Satcher needs no introduction, but I do want to share with you a few of his accomplishments to illustrate his commitment and tireless efforts in eradicating the inequities of healthcare in this country. Dr. Satcher is a physician scientist and public health administrator with an extensive track record of leadership, research, and community engagement. He is a Phi Beta Kappa graduate of Morehouse College and holds MD and PhD degrees from Case Western Reserve University, where he also was elected to Alpha Omega Alpha Honor Society. Dr. Satcher served as the 16th Surgeon General of the United States of America from 1998 to 2002, and the 10th Assistant Secretary of Health in the Department of Health and Human Services from 1998 to 2001. He also served as Director of the Centers for Disease Control and Prevention and Administrator of the Agency for Toxic and Disease Registry. Dr. Satcher has held top leadership positions at the Charles R. Drew University of Medicine and Science, Meharry Medical College, and here at Morehouse School of Medicine, including his role as NCPC Director from 2002 to 2004. He has received over 50 honorary degrees and has earned numerous awards from diverse organizations and agencies. Currently, Dr. Satcher is the founding director and senior advisor for the Satcher Health Leadership Institute at Morehouse School of Medicine. Welcome, Dr. Satcher. Drs. Russ and Mack, please return to the virtual stage. Dr. Cohen, the floor is yours. Thank you.
Thank you, Ms. Wells. It's my pleasure to be here today to help moderate this fireside chat discussion. I am very excited, but also kind of a bit nervous to be here talking with you all because you are leaders that I really admire and look up to. I think we should start with just kind of taking a step back and thinking about why this discussion is important to have today. As Dr. Montgomery Rice was mentioning earlier, I think it is important to acknowledge that we are at kind of a pivotal moment in our history where there is a lot of emphasis on health equity, or sort of a national spotlight given the pandemic, as well as everything that has been going on since 2020 in terms of our nation's acknowledgement of our racist past and current history. And so I just wanted to acknowledge that we are currently in a time where there's kind of this pivotal moment, this opportunity to really make a difference. But in that, it's also important to look to people who've been doing this work and learn from your experience and learn kind of what lessons we can take from that experience to build forward. And so I would like to start the discussion sort of looking at the history of NCPC and learn about kind of its creation and the evolution of it. And then we want to hear about the health equity movement moving forward at the state level and national levels. So our first question will go to Dr. David Satcher. As one of the NCPC's founding leaders, we would love for you to share some of the context around the creation of the National Center for Primary Care. Why was it important to create a national center focused on primary care and health equity at an HBCU? What made Congress act on this need and allocate funding to launch the NCPC? What were some of the earlier successes and challenges for getting the NCPC off the ground? Dr. Satcher.
Well, thank you. I'm delighted to be able to join you, especially delighted to hear from Dr. Russ, who's been such a great friend and so devoted to primary care and the mission of the Morehouse School of Medicine. So George, let me say again, welcome home. It's great to have you here. It's great to see you continue your dedicated work to bring about health equity. I want to just say that, as you heard, I attended medical school at Case Western, and during that time, and certainly before I graduated, I was committed to primary care, even though I had not actually had training in primary care. A group of us used to get together and go out into the community, sometimes during the day, sometimes at night, to try to better understand patients that we otherwise would only see in the emergency room or in the hospital. And so you become increasingly curious about this relationship between the community and the institution. And of course, by now, everybody has sort of heard the story of my interaction with the faculty and administration about the women who were getting pelvic exams without having available to them sheets to protect their privacy. And that was the time when Case Western decided, briefly at least, that they were going to put me out of school. They decided later that they wouldn't, which is a great thing. And I won't tell that full story because it's now in writing. But I say that only to say that I've had a lot of opportunities to serve. I've made the best of some of them. There are others that I have not made the best of. But I do believe that primary care is critical. Let me just say that on a morning in 2000, I got up on the campus of NIH where my family and I were living at the time, and I was serving as Surgeon General. And I would get up and go walking every other morning. So I got up that morning to walk around the campus at NIH, and it was, to my surprise, almost 6 inches of snow on the ground at NIH. That was very unusual. It was frightening because on that day, we had scheduled the meeting to plan Healthy People 2010. And so I was really devastated because the government had announced that it was going to be closed. So technically we couldn't do any business. We had invited over 2,000 people to come to Washington to put together Healthy People 2010. And now the government was closed. Well, to make a long story short, we decided that we were going to find a way to go forward in presenting Healthy People 2010. And I called Donna Shalala, the secretary, and she agreed. And we actually had that meeting on that day with 2,000 people from out of town, which was the main reason we were able to have it, because they had come so far and given so much of their time already. But we only had 2 goals for Healthy People 2010, just 2. The first one was to improve the quality of life, especially of people as they got older, so healthy aging. The second goal was to eliminate disparities in health. Now, as most of you know, that was actually the first time that we had used the word eliminate when it comes to disparities in health. In a way, you can say it was the birth of health equity goal setting. But we did, and we had a great meeting, and the government did not protest because we held it on a day that the government was officially closed. But it was the beginning of our commitment to health equity. And ever since that time, I think we have been struggling to continue this path to health equity. There's a lot more I can say, but I'm going to stop there because I want to hear your questions and concerns as it relates to that.
I would love to hear sort of how the government was involved in terms of supporting the NCPC being founded. Especially since you said with the piece of the Healthy People 2010, you did this intentionally on a day when they were not working. So just to hear a bit more of the history there.
Well, we did it on a day that the government was not open, but we didn't know that the government was not going to be open when we planned it. But in some ways, I guess it did help. But I think the fact of the matter is that we had been working toward those goals for a long time, and getting to the point where we were willing to make the commitment to the elimination of health equity was something that developed from people throughout the country who were working in various places. You've heard Dr. Russ talk about the people out there in the field who worked to make things better. And that was the case here. There were many people who were working toward the goal of eliminating disparities, even though it had never been pronounced at the federal level as a goal. So I think it's fair to say that there was a united front toward moving towards something that was more measurable, even though it may not make us look as good as saying we're going to reduce disparities in health. Saying we're going to eliminate disparities in health certainly was a challenge to us and to everybody involved in this movement in terms of health equity.
Fantastic. I'd like to ask Dr. Russ a question as well. Dr. Russ, you were the NCPC director for 10 years. really through a lot of its formative years, and you also helped with its creation as well. Would you be able to tell us kind of about some of the early priorities and programs and highlight some of the center's early successes?
Sure, thanks. And give credit where it's due. You know, Dr. Lewis Sullivan, I think was a strong leader in terms of identifying the possibility of creating a National Center for Primary Care. Dr. John Maupin, who is a previous president of Morehouse School of Medicine, was executive vice president at that time. We were having conversations then about that. I don't know all the stuff that went on. Dr. Sullivan was involved. Dr. Satcher, I think, was involved as well with Congress in terms of cajoling, arm twisting, guilt tripping. I'm not sure what all happened there, but Congress decided that our nation needed a National Center for Primary Care and that they would fund it. And they explicitly decided that it would be at a minority institution, a minority serving institution. So the foundation for making sure that this center would be focused on both primary care and health equity right from the outset was written into the legislation that established the National Center for Primary Care. Now, I had the opportunity in that time period to put some details to it. I wrote the grant that ultimately was submitted under that congressional funding opportunity. We were able to get funding, $15 million to build the building, which was lovely. But in another way, it was a bit of a challenge. They gave us $15 million to build the building. They said, you got to raise another $5 million because it's going to be a $20 million building. And it's going to be called National Center for Primary Care. So everybody's going to think you got to do a whole bunch of national stuff, but we're not going to give you a dime for programs or people or staffing or anything else. So it was good luck. God bless you. I hope you make it. But there were written into the establishing legislation some parameters that made sure that we kept our focus and didn't just use it as another building on our campus. It had to be national, it had to focus on primary care, and it had to focus on those who could benefit most from primary care, and issues of health disparities, health equity were written into that legislation. So we were able to do that, and that's what the early years were about before the building was finished. I got to be involved in leading the establishing a program, sort of putting meat on the bones. My view was, if I go tell people we're the National Center for Primary Care, is that even going to pass the giggle test? You know, they're going to say, well, who are you guys to be doing that? But we had to establish programs. We had to establish credibility with funders, as well as with the broader group of stakeholders that are interested in primary care and health equity issues. So before the building was even opened, I think we had 12 or 15 grants and contracts, programs. For example, the crash course in cultural competency was funded, emphasizing issues of culture and respect and sensitivity and self-awareness and cultural humility. And an ongoing training program in that space was one of our funded activities. We had some activities with the state of Georgia in terms of looking at the cost of disparities and how addressing disparities and eliminating variation in outcomes could actually significantly save money and improve outcomes for everybody. So we put some meat on the bones in terms of establishing credibility, making sure that if they gave us money, we delivered what we said we were going to deliver, doing things that we thought were meaningful. Every week in the hallway, if I passed our dean at that time, E. Nigel Harris, I can't do a Jamaican accent, but he would say to me, you know, what's national about it, George? And he would say it as he was walking past me, and he would just keep walking. He would just deliver it as a rhetorical question. So what's national about it? And I would, you know, kind of say, well, we've got a contract with Georgia and we're doing this local Atlanta program. And what are we doing that's national? So one other thing I'll mention that I think was a real key moment for the National Center was we had already begun the faculty development program, first in the family medicine department and then establishing it for other clinician faculty, clinician teachers at Morehouse School of Medicine. And with the National Center for Primary Care, we realized there was an opportunity. When we started that program, there were only 36 African-American teachers of family medicine in the whole country. And half of them were teaching at historically Black institutions. So there was a need to build a farm team, to build the pipeline of faculty. After we had been successful for a while, we had graduated more than 100 people from the program. We realized this has the potential to have national impact, and we opened up an executive faculty development program where people from around the country could come for a week at a time, 4 times a year, and engage in our active learning, hands-on coaching workshops around how to teach, how to write, how to do research, et cetera. We had a participant come from a university in California, and it was bittersweet to hear this. She said, "This is the first program in which I've ever felt nurtured or supported as an African-American woman in academic medicine." And it broke my heart to hear that, but it also made us feel like we were maybe doing something that was important.
No, that's definitely super important work. I can relate to that, and coming to Morehouse too for training. Dr. Mack, you were the NCPC's co-director with Dr. Russ for several years before you became the current director. How have you seen the NCPC's mission and core focus areas evolve over time?
Thank you, Dr. Cohen. First, let me speak to mentorship, because these two giants are my mentors. Dr. Satcher was my president at Meharry. He used to have to tell me to get off the corner and go study. Now that's the corner at Meharry now, not other corner, but the corner at Meharry. But I came to Morehouse as a resident, and Dr. Russ came into my life, and he actually stimulated my interest in health equity. And actually eventually came over to the National Center for Primary Care and got to work with him and Dr. Satcher again. So I won't go too much into that, but I'm blessed to have these two leaders and mentors in my life, and they continue to mentor me today. So I always keep a good mentor. That's one thing Russ taught us in the faculty development program. We teach it today. Yeah, of course, what we're doing today is built upon the leadership and the teams that were in the NCPC before us, but the healthcare environment has changed, and it's evolved through our terms to where it is today. But there are new challenges around policy, the way health systems are managed, the way insurers play so much of a big part. And it starts, we have some of the same challenges as community-based organizations, really, being a center. And there's always an infrastructure challenge. You have to build a strong infrastructure and culture within the organization. And that's what we've tried to do within the NCPC, build up our leaders to become more national, as Dr. Russ talked about. But we provide leadership training for our teams. We encourage our team within the NCPC to be leaders and to play a bigger part in developing a culture that really believes the message. And that's so important, as I stated, with community-based organization. And as a leader, a good leader, as we heard from Dr. Russ in his talk, it's about making other leaders, making everybody's a leader. One thing that Dr. Satcher used to say that used to always impress me was, "I'm not a politician." He would say, I've heard it, they would challenge him and try to, like Jesus, they would try to put him on the spot. And he would say, "I'm not a politician." So, but he really approached it in that manner. And we're not politicians. We're not here to just self-promote. We're here to make other leaders. So leadership is so important internally, but also as far as the center is concerned, we've had to look at making sure that we go into the areas of innovation, technology, because that's so important in practice these days as it wasn't before. Electronic health record, digital health tools. Policy has become a bigger part of what we do every day, and we work with the Satcher Health Leadership Institute in that area, but actually understanding policy and actually doing research in the area of policy. We've expanded into that. How do we be sustainable? It's more of a business model that we've tried to implement. And that's one thing before Dr. Russ turned the reins over to me, he talked about. He said, you're going to have to, interject some of that business knowledge into what we do as we go forward, because you have to be successful when it comes to funding and raising money these days, more so than before, because of the challenges with funding and really the way the funding mechanisms are built. We've broadened our partnerships, but we've also we've developed an international program. We're in Zambia and Malawi, but we're really primary care and the lessons we're learning from the US, we can share those in Africa, but also we're learning a lot in Africa, but we share some of the same problems and we're seeing that. So those are some of the areas, but I think overall, trying to be sustainable in a healthcare environment that constantly changes. And then of course, with the research, the big data, health equity research we're doing, now we're doing COVID. So just being nimble and changing with the health issues that are affecting primary care and prevention every day. So those are some of the things that we've done to kind of try to help evolve with the changing healthcare environment.
Those are all fantastic things. We have a few questions that we'll get to in a bit from some of the audience members. But I'd like to kind of broaden the discussion a bit and hear from each of you what you see as sort of the most notable accomplishments in the journey to health equity thus far, from all of your different viewpoints. And then also kind of the flip side of that, what you see as some of the biggest challenges remaining in our efforts to achieve health equity. We could start with Dr. Satcher. I know you spoke about Healthy People 2010 and how switching the language from reducing health disparities to eliminating health disparities was huge, like a small change, but had huge effects in terms of the focus. So if you could speak some more about your accomplishments in the journey to health equity.
Well, I think it's critical to set lofty goals and for those goals to be clear to everybody. And I think that's what we tried to do. We tried to set goals that could be shared by people all over the country. And certainly eliminating disparities in health was a clear goal, but that's setting the goal is the beginning in a real sense. Then we have to get people together to talk about strategies for how we're going to reach those goals. And you've heard a lot of that already today from Dr. Russ and others. But I think there's no question about the fact that getting people together on a national consensus to eliminate disparities in health and achieve health equity is no easy task. And it's never done. That task is never done. We continue to work to achieve the task of eliminating disparities in health and achieving health equity. But I think it's the kind of task that we need to set for ourselves, the kind of goal that we need to set for ourselves. But then beyond that, we need to work with people all over to try to achieve that goal. What are the barriers in different communities to achieving that goal? The barriers in Los Angeles County, where I started my career after Rochester, were different from the barriers in Atlanta or in Nashville, Tennessee. So what we have to do is to find the barriers that we have to overcome in every community in order to achieve health equity. And you've heard about some of the other communities and what was done to try to overcome that. But I think the whoever came up with the idea of setting goals every 10 years deserves a lot of credit, because it keeps all of us on track, and clarity. It brings clarity to why we're here and what we're trying to achieve.
Yes, I agree with setting the 10-year goals. It keeps us accountable, which is incredibly important in terms of achieving health equity. Dr. Mack, what would you say are some of the challenges that we're currently facing in pursuing health equity?
I think one of the biggest challenges, in which we're seeing now, we're working with organizations, is speaking to communities, conveying valid, truthful information that can help, can get them into preventative and primary care. If one thing we see with COVID, we talk to communities, and Dr. Russ touched on it. You know, we look at the community and say, okay, they're not getting the vaccine, that you know, they don't understand. Well, you know, you had politicians and medical leaders who was saying, don't get the vaccine and don't get tested. So the community doesn't really know who to trust, or they're not trustful. I think our biggest challenge is making sure that we can develop programs with messaging that is truthful. And truthful is, you know, truth can be in the eye of the beholder. So what is their truth, right? So those are cultural barriers that we have to overcome. And communities are different. One thing we've learned, and you know, Morehouse is a predominantly African-American institution, and we deal predominantly with that community in most cases. But when we deal with the American Indian community, Pacific Island community, or the Hispanic community, there are similar issues and problems, and the necessary solutions can be similar in some cases, but there are big differences. And even within a ethnic group, there are different cultures. With no matter, you go around town in Atlanta, you can go to different communities and you have different challenges, you have different beliefs. So how do you develop programs, no matter what they are, you know, whether it's around the research, the policy, interventions, the implementations, the clinical services? How do you make sure that they're culturally relevant? And again, that was in one of Dr. Rush's slides, not what you believe is relevant. Even as an African-American dealing with African-American organization or community, but what do they believe is relevant? What works for them? So, especially after COVID, and let me say this, and we've had over 1 million deaths, but we're 80-something million infections, and we're the greatest health system in the world. That doesn't make any sense. All because of debate and interjection of falsehoods, etc. However you want to look at it. But communities really awaited good leadership and good messaging, and that didn't come. So, you know, again, as Dr. Russ said, you can't blame the community for that. We have to blame the way we presented the messaging. So that's one of the biggest barriers in my mind.
Thank you for that, Dr. Mack. I 100% agree in terms of the messaging, especially with this pandemic. And I like how you spoke to the fact that, and Dr. Satcher as well spoke to the fact that each community is different. So you really have to go with the truth of that community. Dr. Russ, as we said, every community is different. You're currently in Florida, so would love to hear your perspective with your work there. But what do you see as sort of, well, we can speak positively about some accomplishments, but also some of the biggest challenges that we have right now?
Sure. Well, I am in Florida now, and this is also the first time in my career since medical school when I've been at a historically white institution and a predominantly white institution. And I caught myself one day after about 3 months here And I didn't even know what triggered it, but the thought came through my head, gosh, this place is white. And and yet we lead a lot of the majority institutions in terms of the diversity of our students and stuff, but culturally, we still have that white majority culture. And so I say that to say that one of the transitions we need to work on is helping all of the institutions, whether it's hospitals or medical schools, that are historically white, that have a historically white majority culture that doesn't feel like a specific cultural subgroup, but just feels normal because it's the majority culture. Helping those institutions make the transition to knowing that they live and work in a non-white world. And that means changing their leadership suite sometimes, making sure that they're oversampling minority voices, that the community, that there's vertically proportionate diversity at all the power levels from front desk clerk to CEO and governing board. So helping sort of majority or mainstream institutions really get their heads around the transformation that will be required to become institutions of equity, I think is one of our significant challenges. And the flip side of that, I think, is a wonderful thing that I watch happen. And Dr. Mack has really taken this to a whole nother level in his leadership of the National Center for Primary Care. When we were first trying to raise funds for that last $5 million for the building, the Woodruff Foundation in Atlanta gave us $2.5 million to help jumpstart that process. I was thrilled. Fantastic. 2 weeks later, they announced that they were giving a $500 million gift to Emory University to endow its health professions programs. And what happened in that moment was all of the inequities, the institutional inequities of the 19th and 20th centuries were now locked in for the 21st century because of the resources and the endowment that they had now put in place that would carry that institution forward. And the imbalance between resources was now in concrete. I mean, it was just solidified in an incredible way for me. And I had trouble communicating about that at the time. It was like, well, thanks for the gift. I mean, $2.5 million is not nothing. It was not chump change to us back then, but 500 million is now we've just structurally reinforced the inequities. What I think has happened, and it started really with the establishing of the National Center for Primary Care, is Congress realized, was helped to realize, that a National Center for Primary Care ought to be at a minority serving institution. That's the natural home for it, that if we are to address the primary care needs and challenges of our entire nation, then we need to start with where it's needed most and where it's understood best. And so in the early days, we would get $10,000 from this foundation or $100,000 here or there. And there was some convincing, overcoming of their implicit bias that, can a small minority institution manage the money well and all that sort of thing. And I think we've gotten beyond that to where Congress realized Morehouse School of Medicine was the right place for this national center, where when you're going to do a $40 million grant to deal with COVID in this country and create a resiliency network, where do you send the $40 million? You actually send it to Morehouse School of Medicine. You send it to a historically Black institution. So I think there is an emerging understanding of the value of the contribution of minority institutions, but I don't think we've yet really kind of gotten all the way there with the sort of white denialism or the sense that us white folks live in majority culture that feels normal to us, and we don't notice when we're behaving culturally. We don't notice when we're holding on to the power. We don't look for the opportunities to give away privilege.
Oh, that is definitely so true. And I kind of want to speak to what you're saying about how majority white institutions sort of need to start changing what the C-suite looks like and everyone in leadership. We have a few questions from the audience, specifically talking about what you all think might be some strategies and ways to better recruit men of color to be working in this space. Any ideas that you'd like to share?
Well, I think one thing we have to do is to start early, and we have to start earlier than we're starting now. We're losing many of our young Black males before they even get to junior high school, because we're creating a kind of environment where they find something else more attractive. So one thing I would say is that we've got to start as early as we can. We've got to be better role models, and we've got to provide support, because a lot of the young Black men are growing up in environments where they may not see Black men as role models in those communities. So I think working on those areas is a start anyway, in terms of the journey toward increasing Black male representation in medicine, research, et cetera.
If I can just piggyback one comment on that real quick. The institution I'm at now, Florida State University, has a $2 billion budget every year. And so aside from changing the C-suite and the governing board to be more representative of our community of Florida, the diversity of Florida, imagine if we looked at a $2 million budget, and every salary line that's attached to that, every construction contract that we give out, if we looked at every one of those dollars as an opportunity to address social determinants, to create career paths in neighborhoods with high unemployment rates, to create opportunities and hope and change those areas that some people tag with deprivation index kinds of scores. We have the opportunity, I think, again, in the larger institutions, to dramatically make a difference in that space with our resources that are overly concentrated in communities that historically have been able to get the contracts and get the salary lines and so forth.
Yeah. Quickly, I say, and the colleague said it, mentorship is important, but also we started a study that we yet to finish, but there have been studies about the distribution of funding to community-based organizations. And NIH funding has been looked at, and how much of that funding actually goes to community-based organizations are minority, those minority-based community-based organizations, and there's very little. One thing we had talked about and proposed is, with all the research and funding, which are predominantly done by majority institutions, we've heard about the parachuting into communities. You do the research and then you go. Kind of to what Dr. Russ is saying, wouldn't it be wonderful if NIH required recipients of funding to develop pilot programs and to develop researchers within communities as a criteria for getting some of this funding? Not just doing research on communities, but developing kind of like those, some of this, a significant amount of the funding would require these academic institutions to make researchers out of the people they're doing research on. So that's one of the things that, research mentoring, but in a realistic way that could make change in community.
That's fantastic. I especially like the idea of kind of cultivating the community that you're working with and making researchers out of the people that you're working with in the community. We have a few questions coming in from the audience. Give me 1 second. Let's see. Okay. So I have a bit of a question of my own that kind of ties into this conversation. But since we have all three of you leaders for on stage right now, do you have any advice for young emerging health professionals who are interested in pursuing a career with a focus on pursuing health equity? I know Dr. Mack mentioned a bit about mentorship, but anything else that you'd like to say to our audience?
Well, I can start on that one. Yeah, mentorship, but making sure that you get a mentor. That's one thing with teaching and faculty development. It's important to get a mentor. Don't just get somebody you like. And often we do that. Get someone who can really, be objective in the field that you or the direction that you're going into. I think it's so important that you really know yourself to a certain extent and give yourself time to find out what you really want to do. So many people look at a leader and say, I want to be that. You have to really understand what it takes to be a leader, but see if that's really what you want to do. You don't want to get so far down the road and really you see, okay, this is not for me. We're seeing a lot of that in the clinics these days. I always say to folks, a job is not a career. You do take jobs that you don't like on the way to a career that you like. So kind of give yourself time to understand what it is that you really want to do by kind of testing out different areas of the field, talking to people, and also, again, that mentorship that you have. And be a servant leader. It's shown over and over again that people are happier when they serve. Look how happy Dr. Satcher and Dr. Rust are. They're smiling right now. When you're a servant leader, like Dr. Satcher, don't be a politician. It's not about you building, you're not trying to be a politician, build your name, etc. If you serve those that you work with, whether it be community, your team that you work with, you're much happier and you can do your job a lot better. And if you learn that earlier, I think it's important.
I would just say two things. First, find the people who nurture you and particularly nurture your idealism. In medical school, I could count on 3 fingers the number of people who would give me affirmation if I said I wanted to do primary care in an underserved setting. It just was not an environment where they thought that was something that was a high and noble calling. There were individuals there who did, but so when I transferred after my first year of internship over to Cook County Hospital and entered a program that was led by Dr. Jorge Prieto, who had been a physician to Cesar Chavez at one time, and the opportunity to have people who nurtured my idealism was critical. And then the second thing for me was figuring out what I'm built for. I always pictured myself just seeing patients all day long in a clinic and doing service in primary care, and that would be a good and noble calling. But it turned out that I needed some time sometimes to step back and think about bigger picture stuff and to write about it and to maybe do some research that could create tools for advocates. And I found my groove and to some extent found what I was built for. So I think those two things: find the people who nurture you in your idealism, and then figure out what you are best suited to do. Where on this battlefield of health equity would you best serve?
I want to agree with that, and I also want to leave you with a quote from the Satcher Health Leadership Institute. It is that in order to lead effectively, we need people who care enough, people who know enough, people who have the courage to do enough, and people who will persevere until the job is done. We share that with people applying to the programs of leadership, and we share that with people doing their development as leaders. Caring, knowing, having the courage to act, and persevering until the job is done.
Thank you so much for all of your contributions today. We have had a fantastic discussion, and we have run out of time. I had one last question for you, but I don't want to steal time from Mr. London and Phoebe Nelms. But thank you all for sharing your insights today.